Good morning, dear colleagues, ladies and gentlemen. I would like to thank the organizers for inviting me. It is certainly a privilege and a pleasure to be here. I am talking about the treatment of Alzheimer's disease, and I will be concentrating in my presentation on pharmacological treatment. You will hear about non-pharmacological presentations, non-pharmacological treatment in the third presentation by Professor Vernooy. In order to understand how present treatments work and how future treatments will work, or are supposed or hoped to work, we need to recapitulate what Alzheimer's disease is. Well, it is a complex cascade of pathological events. What you see here are 4 neurons, and you will see these 4 neurons throughout the presentation. I hope you can see them. Now, the pathological cascade starts when enzymes cut a small piece out of a larger worm-like molecule which sits in the membrane of nerve cells. And this creates a fragment which we call beta-amyloid. Beta-amyloid has a propensity to aggregate, and it forms small complexes which are still soluble. As long as these complexes are soluble, they are removed and digested by other enzymes, so no harm occurs. And there are also mechanisms which transport beta-amyloid out of the cells using active mechanisms which sit in the walls of blood vessels. When there is an imbalance between the production of beta-amyloid and the removal of beta-amyloid along these normal pathways, then the small complexes aggregate into larger complexes, and these are the nuclei of the plaques which you have frequently seen. These plaques, and probably also, or maybe even more so, the smaller complexes, are toxic, are dangerous to neighboring nerve cells. Dendrites of neighboring neurons degenerate and do not function properly anymore. So the signal transmission across nerve cells is compromised. And a second consequence is that tau protein, which is a very small protein that stabilizes microtubules, transport organelles in nerve cells, aggregates into twisted fibrils, which block the transport of neurotransmitters along the axon of the neuron, and therefore, at the end of the cascade, there is a lack of normal signal transmission. The damage that occurs to nerve cells can be so severe that the nerve cells dissolve. And if these nerve cells are cortical nerve cells, then they contain a neurotransmitter, a signaling substance, which is called glutamate. And once the nerve cells lose their integrity, they spill glutamate out. And glutamate overstimulates nerve cells in the neighborhood. So there is not only a lack of normal neurotransmission, but there is also an excess of abnormal neurotransmission, so the brain cannot work well. And these processes, which go on for decades in the brain, they gradually destroy large parts of the brain. What you see here is a time bar showing a total duration of the disease of approximately 30 years. And on the left, I hope you can see, there's always the left side of the brain, and shown in dark is where the changes, the pathological changes are. Over the first 5 years of the disease, there are no symptoms. The tissue changes are in the lower part of the temporal lobe, but the brain can compensate these changes, so there are no symptoms. The changes gradually spread, but still the compensatory mechanisms are sufficient and there are no symptoms. And this period of the disease approximately has a duration of 10 years. So during 10 years, the disease is clinically silent. Only when the disease spreads to larger parts of the temporal lobe, first symptoms occur, which we usually call forgetfulness, but nothing serious, no disability, causing no disability in everyday life. But over the next 5 years, memory continues to deteriorate, and at a certain point, the damage is so severe that patients are no longer able to maintain their usual activities of daily living, and this is what we call the state of dementia. And only this is when we make the diagnosis of the disease today. And only during the last 5 years of the total duration of this long process, the stage of severe dementia is reached. Now, from this biological perspective, dementia is a late stage of a very long process. Now, how do the current treatments work? Well, they strike at the final leg of the complex pathological cascade. Some of these treatments restore deficient normal signal transmission mediated by acetylcholine. The neurotransmission is deficient because, as you've seen, the neurofibrillary tangles block the transport of the neurotransmitter along the axon out to the terminal. Other drugs attenuate the excessive abnormal signal transmission, which is caused by glutamate, which you've seen before. Glutamate is spilled out of degenerating nerve cells onto neighboring cells and overstimulate them, which is toxic and creates a lot of signal noise. The neurotransmitter acetylcholine is rapidly inactivated by an enzyme we call cholinesterase. This is the yellow triangle. Now, there are compounds which block cholinesterase, block the cholinesterase. We call them cholinesterase inhibitors, and therefore more of the neurotransmitter acetylcholine reaches the receptors at the neighboring or the postsynaptic neuron, and therefore cholinesterase inhibitors restore at least partly this kind of neural transmission. There are 3 cholinesterase inhibitors which you are familiar with, and therefore I will not mention the names. The excess amount of glutamate, which is released from degenerating nerve cells, overstimulates, as I have said, neighboring cells. You can see receptors for glutamate, and the pink dots symbolize glutamate. Now, there is a compound we call Memantine, which sits on the receptors, blocking the receptors, and therefore the overstimulation goes away, and the nerve cell can function normally. There is only one glutamate receptor modulator on the market, which you are also aware of. The clinical effects of current drugs are limited. They can only be used after the onset of dementia, which means that we are starting the treatment very late into the disease process. And the effect of these drugs is a temporary delay in symptom progression, as symbolized by the green line relative to the blue line, which represents the untreated course. So over a number of years, patient can function somewhat better with treatment than without, and the delay of symptoms is definitely a benefit for patients and for caregivers, because quality of life and level of functioning is maintained for longer. But on the whole, you can see that the effects are not large. To illustrate that a bit further, this is an image showing, or graphical representation showing, the effects of a cholinesterase inhibitor. The green line represents treated patients. The blue line represents patients who receive an inactive compound or placebo. The treatment continued over 52 weeks. And this is the way how the results from clinical studies are usually presented. You see a divergence of lines. You see clinical significance or statistical significance at the end. But looking a bit closer, we can see that the effects are not very large. The scale with which the effect was measured is the mini-mental state examination. It has a range between 0, which means no performance at all, to 30, which means the maximum. And the difference that is created by a cholinesterase is approximately 2 points. This is statistically significant, but it's clinically of doubtful relevance. But still, I think it's a benefit to patients. The benefit of cholinesterase inhibitor treatment may be illustrated by this graphical representation. We are looking at another 1-year study with a cholinesterase inhibitor, the green line representing treated patients, the blue line representing untreated patients. And we are looking at activities of daily living. Now, we are looking at the percentage of patients who do not show a significant decline of their functional ability. And there is, at the end of the 1-year treatment period, there is a 16% difference, which means that patients who receive treatment are 60% less likely to experience a clinically evident functional decline. So overall, the treatment effects of cholinesterase inhibitors and of memantine, which has similar effects, is statistically significant, but it is not large. This is a graph showing the effects of memantine, which is very similar. Now, which novel treatments are being developed? Well, novel treatments target events that occur upstream in the pathological cascade, not at the end where the neurotransmitters are affected and are becoming abnormal, but at the beginning where the amyloid is formed, where the amyloid aggregates, where the amyloid is toxic to neurons and creates changes within nerve cells and creates neurofibrillary tangles. There is, as I said, beta-amyloid cut out of its precursor molecule by certain enzymes, so we have amyloid production. There's a number of drugs that are being tested as drugs that inhibit the production of beta-amyloid. Here is a list, and you can see that a number of big companies are investing in treatments that are supposed to block the production of beta-amyloid, including Bristol-Myers Squibb, Eli Lilly, GlaxoSmithKline, Hoffmann-La Roche, and Wyeth. So the big players are in fact trying to develop drugs that work on beta-amyloid production. Then we've seen that A-beta is digested by other enzymes within the nerve cells, and there are drugs in development that stimulate the degradation of beta-amyloid. here are two examples. Ginseng products are one, and there are other drugs. Currently, there are no clinical trials, but preclinical trials are ongoing. Then we talked about the clearance of beta amyloid out of the brain across the blood-brain barrier. And you may imagine that there are compounds in development which enhance beta amyloid clearance. These are two relatively old drugs. They are antihypertensive drugs, which are in preclinical experiments as clearance enhancers. Then there is re-entry of beta amyloid from the blood vessel into the brain, and if we were able to block the re-entry, we would reduce the level of A-beta in the brain, and there are re-entry blockers in development, one being developed by Pfizer, another one by Baxter. They work in different ways, but they are meant to reduce the re-inflow of beta amyloid from the vessels into the brain. Then we have the aggregation of A-beta small complexes into larger complexes, eventually forming the plaques. There are compounds that inhibit the aggregation of A-beta. Here's two examples, one being developed by Prana, another one by Elan. Both are in advanced clinical trials. And there are strategies that aim at removing beta amyloid, which is deposited in the brain, from the brain, using immunization strategies. Immunization strategies can be passive, using antibodies, preformed antibodies, or they can be active, using fragments of beta amyloid that are injected into the bloodstream and reach the brain and create an immune response there. There's a number of compounds of antibodies, a number of active immunization strategies, again being developed by large companies. Here's an incomplete list. And there's a number of antibodies that are in clinical development, including Betaamyloid, of which I'm going to show you some clinical findings. And we talked about the aggregation of tau, which creates the neurofibrillary tangles, which block transport mechanisms within the cell. There are tau aggregation inhibitors. Here's, again, a small list of these compounds. Now, here's two examples of how these treatments work on a molecular level. The first examples show how an active immunization works on the brain. We are looking at a brain section, and what you can see is the depositions of beta amyloid, the plaques. I've marked one. In patients who receive no active treatments, the plaques remain in place. In contrast, in patients who receive treatment, the plaques move away. So the beta amyloid deposits have vanished in this patient, but the neurofibrillary tangles remain. In effect, these treatments, the active immunization treatments, are obviously able to remove beta amyloid deposits from the brain. The clinical effects are not clear yet. And here's another example for passive immunization using an antibody. What we are looking at is an image produced by amyloid imaging using positron emission tomography. You look at a brain section from the top. You see the ventricles, and you see in yellow and in red depositions of beta amyloid, which I have marked. Before treatment, there is a definite deposition of beta amyloid in this particular patient. And after 78 weeks of treatment with an antibody, Betaamyloid, the beta depositions go away. I think this is a rather dramatic effect. Still, the clinical effects are not as clear as these effects on a biological level. So, a number of strategies are aiming at slowing the disease, and what will their effects be? In a schematic representation, we can imagine that these treatments are used earlier in the course of the disease. You have seen a very similar representation before, where the treatment started about 10 years later, 5 or 10 years later, at the stage of dementia. Now these treatments are meant to be used earlier, before patients are severely impaired, before the state of dementia has occurred, and if everything goes well, the treated patients, represented by the green line, will not develop dementia during life. This is what we hope for. This is the vision. Which also means that the total duration of the clinical course from diagnosis from diagnosis onward, the time during which patients and their families have to struggle with the disease will be much longer than we are seeing it now. In the insert on the left, you see the clinical duration of the disease, which is about 6 years. With new drugs, if they are safe and effective, this period of active coping with the disease by patients and by carers will be prolonged to maybe 10, 12, or even more years. To conclude, the current medications address the final leg of a complex cascade of pathological events. The benefits of these treatments are of moderate size and of short duration. Novel treatments are being developed which target upstream events that are earlier in the pathological cascade. The aims of these strategies are to slow down the pathological cascade and to prevent severe cognitive decline and the disability that ensues from it. As you have seen, there are several different strategies, many different strategies that are being pursued, most of which focus on lowering the production or deposition of amyloid or increasing the amyloid clearance. So a lot is happening in drug research currently, and I think that never before so much money has gone into the development of drugs, and there are a number of very promising candidates. In conjunction with early diagnosis, the novel treatments will provide extended time and greater ability for coping with cognitive impairment because patients start at a much higher level of functioning. The novel treatments will therefore increase and not reduce the need for and the prospects of non-pharmacological interventions. With this, I would like to thank you for your attention. You are looking at one of our study patients and one of our study nurses.